Chapter 22 covers abdominal emergencies. The abdomen is the region between the diaphragm and the pelvis. It contains a whole bunch of organs, solid organs, hollow organs. All these organs do digestive work, reproductive work, making babies, making new ones, endocrines, and regulatory systems of the body. This is basically everything that's keeping everything going in the body, minus the brain, heart, and lungs. Organs within there are the solid organs. The spleen is located in the upper left quadrant. The liver, very big, upper right quadrant. Pancreas, right kind of in the epigastric area of the body. And kidneys on the posterior side, kind of towards the flanks. Hollow organs, you have your stomach, kind of tucked up in behind the in the spleen area, in behind the liver, kind of sits in the middle. Gallbladder, really tiny, upper right quadrant. The duodenum is the bottom part of the stomach there. Then your large intestine, kind of transverse across the belly, and the small intestine in the lower left quadrant of the belly, and a bladder down in the pelvic region. So the intestines take up the majority part of that abdominal area. So the abdomen is divided up into quadrants: the right upper quadrant, left upper quadrant, right lower, and left lower quadrants. Also in the epigastric region. Epigastric region is just a small place right about the xiphoid process. So to divide up the quadrants, basically the belly button is the bullseye. So that belly button will be the center of the cross, dividing those regions laterally and vertically. The abdomen is lined by the peritoneum. That's just a thin membrane that covers the abdominal cavity. The parietal peritoneum is attached to the abdominal wall, and visceral peritoneum covers each of the organs. So basically this is just a thin membrane that acts as kind of the sac that all the organs stay in, keeping everything lubricated so they're not sticking to one another and keeping them all intact. Most of those organs are within that parietal peritoneum. There are a few that lie in the extraperitoneal space, basically just right outside that peritoneum sac. So they just kind of take up their own space, and most of those lie on the posterior side of that sac. Such organs include the pancreas, the duodenum, the aorta, inferior vena cava, the fallopian tubes, part of the colon, the uterus, rectum, and the bladder, whereas most of the big solid organs and hollow organs are within that peritoneum space of the spleen, the liver, gallbladder, stomach, the intestines, bowels, all the other stuff right in that peritoneum sac. So now we'll talk about abdominal pain and discomfort. Visceral pain comes from organs within the abdomen. These organs have fewer nerve endings, so they don't have that pinpoint pain. It's just kind of a dull or achy sensation. Can't really pinpoint exactly what organ is coming from. So that dull, achy pain is visceral pain. Visceral is achy and dull. Colic pain is pain that comes from generally the hollow organs, caused from distension or contraction of those. So intermittent pain that's not really able to be pinpointed generally come from the hollow organs like intestines. So just think about when you've had those belly aches and cramps, how it kind of comes and goes. That's generally just the colic pain. Persistent or constant pain is coming from those solid organs that contain more nerve endings. Parietal pain comes from organs within that parietal peritoneum. So when you have many nerve endings, you'll have a specific sharp pain. So those solid organs are going to have that pinpoint, sharp, easily to identify severe pain. Tearing sensation comes generally from the aorta. So it talks later about abdominal aortic aneurysms, sharp tearing pain in the abdomen can be from the aorta. Where it's in the retroperitoneal space that causes the pain to be referred to the back as well. Referred pain is basically pain that's felt somewhere else, and that's just from nerve pathways sharing a common pathway and overlapping. So one area that hurts, say in the right lower quadrant, and it also makes the shoulder hurt. If the whole pathway of pain isn't connected, it's referred pain. But if it hurts all the way from your groin to your shoulder, that's radiating pain. So now we'll talk about some abdominal conditions. Appendicitis is just an infection of the appendix. Be nauseous, often vomiting, and the pain is in the right lower quadrant. Right lower quadrant pain can be appendicitis. That's where the appendix is. Often sometimes referred pain in the umbilical area. So your belly button may hurt along that right lower quadrant pain down in the groin. If the appendix would rupture, severe sudden increase of pain, just crazy amounts of pain, and generally nausea, vomiting, some severe stuff would go along with that. Peritonitis, no medical terminology, itis meaning inflammation or irritation of. So that's just the irritation of the peritoneum space, generally caused by some kind of foreign material in that space, being some kind of acidic stuff going in there, whatever it may be. That space is very sensitive, especially to some type of an acidic substance. So that irritation can cause involuntary contraction of abdominal muscles, so abdominal pain and rigidity. A lot of times hospitals, if a person has abdominal pain that they can't exactly figure out what it is, this is the diagnosis that they get. Cholecystitis, otherwise known as gallstones. That's just inflammation of the gallbladder, generally caused by a blockage by the gallstones. Generally, the pain can be worsened by ingestion of fatty food. So if they've been having some abdominal pain, they eat something really fatty. Asking that last little intake what they ate something fatty, could be an issue with gallstones. A lot of times this is just associated with poor diet. So signs and symptoms is severe right upper quadrant and epigastric pain, often referred to a shoulder. So right upper quadrant pain, referring to a shoulder, generally gallstones. Pancreatitis, inflammation of the pancreas, common in patients with chronic alcohol abuse. So they generally have epigastric pain, and it's referred to the back and the shoulder. So somebody who's been on some heavy drinking binges, having epigastric pain and back pain, generally gonna be pancreatitis. GI bleeding is hemorrhage and bleeding within the GI tract. This could be minor, just passing a little bit of blood, or it could be severe. If we're passing a lot of blood and it's coming out of one of the ends, that could be bad. Patients can go into shock and die from GI bleeds. Most commonly, though, it's not on the severe end, mostly the minor end. The blood generally comes out of the mouth or the rectum, so they're either pooping out blood or they're going to be puking up blood. Sometimes it's painless, sometimes it's worse. Gastric ulcers, which are basically just holes in the GI system from taking a whole bunch of acidic stuff in the gastric tract, can cause that severe pain and peritonitis. So with GI bleeding, dark colored stool, maroon, really black looking, are often referred to as tarry. It's going to be your lower GI bleeding. Having frank blood, that bright red blood, come out of the rectum, generally that's bleeding from a hemorrhoid. If you're seeing just bright blood, or there's just a little bit on the toilet, or they see it mostly when they wipe, that's going to be just generally bleeding from hemorrhoids. If they're vomiting coffee ground like stuff, it's going to look like it's just going to be that dark blood. So the blood's been in the tract for a while, and now they're puking it all up, so it's dark colored upper GI stuff. or if they're vomiting frank blood, again, upper GI. So if it comes out of the mouth, upper GI bleeding. If it comes out of the butt, it's lower GI bleeding. Sometimes it'll be pain, sometimes it won't. So just know that if it's dark blood, that means it's slow. That it's been in the GI tract, it's taken a while to process to come out one orifice or the other. But if it's bright, that's fast bleeding. An abdominal aortic aneurysm, a AAA, a life-threatening condition which a big aorta has the walls of it weakened, and it could rupture and blow out an immense amount of internal bleeding. They'll have a tearing sensation because the aorta is tearing. It's basically dissecting itself, rupturing out from that ballooning of the wall from those weakened vessel walls. And it can continue to grow, get bigger to the point where it may eventually rupture. Remember, handle these patients very tenderly. So it can start out as just progressive, sharp or tearing pain, and gently radiating to the back where the aorta is behind the peritoneal space. It'll be a palpable mass. See a lump on her belly, possibly pulsating from that ballooning pushing out against the abdomen. Sometimes with the aorta being swelled out like that, there may be unequal pulses in the feet. So the left foot may have good pulse, the right foot may have a really weak pulse. If they do have a sudden pain increase, this may indicate that aorta has ruptured. That doesn't mean that they've sprung a huge leak and are going to bleed out immediately, but with that it means they're starting to lose pressure and it's going to be leaking out somewhere. The aorta is under a whole lot of high pressure, so they can rapidly deteriorate and go into a shock. A lot of times it is likely exsanguating, meaning that it's going to be fatal hemorrhage. A hernia is basically just a hole in the muscular layer, the abdominal muscles, that the intestine is starting to poke through. The abdominal muscles will hold everything in place, but if they get a tear, those intestines will push out. Generally caused by heavy lifting or severe straining. That can cause where the intestine can poke out and the abdominal muscles will contract around it. That can cause strangulation and obstruction of the bowels. Most hernias end up being surgically repaired. Sometimes it's just for comfort. Sometimes it is a critical life-threatening illness that they need to do the surgical repair. But most of the time with the hernias, it's just repair to make them more comfortable so they don't have pain on movement and such things as that. Have a sudden onset of abdominal pain, generally worsened by exertion. So it can be pretty close there with similar to a pulled muscle. The difference being you'll probably be able to feel a mass or a lump in the abdomen or in the groin regions. So here's an illustration of a hernia. You see the intestines have poked through the abdominal wall. The fatty part of the belly, the intestines have poked through it, causing that lump, the mass that you're going to feel. But where it's poked through the abdominal muscles, this can cause a constriction of it, so the intestines are now blocked and nothing's able to transverse through the intestines. Renal colic is that severe flank pain, generally caused by kidney stones traveling down to the ureter. So signs and symptoms of it: severe or cramping like intermittent pain in the flank or the back, pain right where the kidney's at, and frequently it's going to radiate all the way down to the groin. They can be nauseous and vomiting or just have severe pain. Most of the time this is caused by poor diet stuff, not drinking water, just living on monsters and coffee and things like that. Cardiac pain can mimic just regular epigastric or abdominal pain in that high epigastric area. It's not always that severe chest pain going into the shoulder and the neck. So if we're having epigastric pain, don't just assume, oh, it's probably just pancreatitis. Always consider that possibility that it is a cardiac related more so than just one of the organs in the abdomen. So always treat worst case scenario. So how to care for these abdominal pains and discomforts. There can be a whole lot of things that go into the cause of that abdominal pain. Basically, the EMT, their big job is to not diagnose and say, yes, it is pancreatitis, but it's to do really good assessments and be starting to scratch some things out, doing a good differential diagnosis of trying to see possibly what it could be. So really good, thorough exams is the biggest thing that's going to go into these. So as always, primary assessment consists of that general impression, level of consciousness, and the A, B's, and C's. Also with that, consider giving some supplemental oxygen. If they're having abdominal pain, it may hurt for that diaphragm to move up and down. So the respiration or their quality of breathing may be a little bit labored just because it's really hurting them to breathe. And asking the history of that present illness of the OP, QRS, and T. So onset, when did it begin? Exactly what were you doing when all this started? Provocation, anything make it feel better or worse? Any positioning, does it feel better laying in the fetal position, laying flat? Describing the pain, the quality, how bad is the pain? Region and radiation, can you identify exactly where the pain is? Is it diffuse pain going everywhere? Is it radiating pain? Is it sharp pinpoint pain? The severity or scale 1 to 10, how bad is it? And time, does the pain happen all the time? Is it intermittent? Has it progressively gotten worse? Is it getting better? Also, when asking those questions with female patients, asking some personal things. When was your last menstrual cycle? Have you had anything like this before with menstrual cycles? Are you late on your period? Are you sexually active? Is there any possibility you may be pregnant? Then asking more detailed with those female patients, anything like this before? As you should really always ask every patient, but females, lower pain could be related to OB. Asking if there's any possibility they're pregnant, are they on birth control, are they sexually active? If they're not on birth control or sexually active, could be a very good chance that they are pregnant. In the past medical history, sample, allergies, medications, past pertinent history, that last oral intake, remembering if they just ate something really fatty, could be the culprit, and events leading to this emergency. With some older populations, they have a decreased ability to perceive any pain. Some of their nerve endings and stuff are just kind of wore out, so their pain may just kind of always be dull. They may not have that exact pinpoint pain. They can have more serious issues with GI stuff. Sometimes they can be life-threatening. Some folks who have uncontrolled GI bleeding can very much so be life-threatening. This can be complicated by some of the medications they're on or some treatments they may be getting, such as chemotherapy or something like that. When assessing that abdomen, always look before you touch. So touch the bare skin, get the shirt lifted up, inspecting for any kind of distension, discoloration, protrusions. If you see any kind of bruising or masses, palpate with your fingertips and do that painful area very last. If you poke them in a sore spot first, they're going to be guarding and have a rigid abdomen the whole time because now their abdomen hurts even worse. So you're looking for any kind of rigidity, meaning that belly's really hard. Any pain to the areas on palpation. So if the pain is worse upon palpation, be sure you document that and relay that. Or if they're guarding, I mean, if they're just got their arms across their abdomen, they don't want you to touch it or do anything to mess with it. General rule of thumbs with the abdominal pain patient, a lot of this stuff just kind of ties into digestive orders, but it can be cardiac related as well, or it could be tied to diabetic issues, food poisoning, the flu. The big thing is just doing really good assessments, asking good questions, doing really good physical exams. Pay particular attention in case this patient begins to vomit. You need to protect that airway, so suction if you need to. If they throw up just once and they're still okay, they're breathing fine, you don't have to worry about suctioning. But if they're laying on their back and they're vomiting, you may need to be suctioning these patients. And always work to calm the patient down, reduce that anxiety, because sometimes they can just be flipping out because their stomach hurts so much, and it just makes everything else that much more worse. And don't give the patient anything by mouth. We don't want the patients to be eating or drinking on the way to the hospital. For one, that's just more stuff they can throw up onto us. And two, the hospitals don't want them to be eating anything in case they are having some kind of major GI issue, in case they need to go in and do something.